Good afternoon to everyone present here with us today. This is Trion from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. P. M. Gopinath. Sir is MBBS, DGO, MD, Director and Senior Consultant at the Department of OBS and Gynecology at the Institute of OBS and Gynecology and IVF. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is recent advances in assisted reproduction. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Good afternoon. Thank you very much for the kind invitation. I'm really happy to be here in one of the most prestigious series of CME programs conducted after the memorial of Dr. K.K. Agarwal. I'm really honored to be a speaker. In fact, this is the second time I'm speaking on it. And today I will be covering on the newer developments in assisted reproduction. Is my slide visible?
Yes, sir, it is visible.
Yes. So here you will see Professor Patrick Robert Edwards. He is the embryologist who has been involved in the first test tube baby Louis Brown in 1978, and he has been awarded the most prestigious Nobel Prize. So this has evoked a lot of interest, and then it has just started on the various aspects of the ART programs now. If a man and a woman try to achieve a pregnancy, they take about, in a first month, they take about 0.2 is the monthly probability. Cumulative probability is 0.2. If as you go up at the end of the 1 year, you will see that they really sort of, it takes the cumulative pregnancy rate as low as about 0.98. So that means you have to give them sufficient time, number one. In a cycle, you can expect only about 20% of the pregnancy rate. Now, as I've said, you have to wait. You have to patiently wait. But unfortunately, on the other side, the clock sticks. All couples, 1 in 10 couples are infertile. If you take the age between 30 and 34, 1 out of 7 are infertile. If you take 35 to 39, then you will see 1 out of 5 are infertile. So, but by the same time, if you look into this, the last thing, ages 40 to 44, 1 out of 4 are infertile. So as the age goes up, the incidence goes high. So there is chances of conception is there. What is the problem with this? Why it is so? Why is the increase in infertility? One is a delayed marriage and childbearing, incidence of sexually transmitted diseases, hormonal contraception, abortion, obesity, environmental pollution, and stress, more than one factor acting at any given time. The common cause of infertility, when you say on male, it is roughly about 35% in a couple, and in a woman, exact this is not known. If it is the ovulatory, in a couple, it is 25%. For a woman, it is 40%. Tubal, it is 35%. In a woman, it is 40%. Unexplained in both the groups are 10%. There are other causes which is seen in a couple by about 5%. In a woman, which is about 10%. What is assisted reproductive technology? It refers to all technique involving the direct retrieval of the oocytes from the ovary. The oocytes should be taken out of the body, we have to perform some procedures like IVF, GIFT, ZIFT, and ICSI outside the body. And then the resultant embryo is replaced back into it. So the simplest ART procedure, IVF, has been done around 45 years ago, and it is perhaps the most commonly recognized ART of all procedures today. Major philosophical and ethical shift in reproductive medicine is this IVF. The emphasis has changed from healing and eradicating the disease to control procreation. So if they come with some issue, you try to sideline, give them a baby encircling the normal passage. That is the major shift here. You will see these two gentlemen on the top. This is Patrick Steptoe and Robert Edward, who has done that pioneering work, and you will see them. They have just been with the birth of the Louis Brown, the first IVF baby in 1978. Now, who is eligible for ART? Women with a tubal disease where they cannot reproduce other side. If they have failed microsurgery, they are eligible for ART. Unexplained infertility, where you see there is no other cause made out, they are eligible for ART. Moderate endometriosis, mild endometriosis, they can do simpler procedures. Moderate endometriosis, you do ART. Immunological causes for infertility, women with premature ovarian failure, very limited number of eggs can be taken out of that woman. We don't want to miss the chance. They have to go in for only IVF. Individuals with a male factor, abnormalities in the count, motility, and morphology. There may be a lot of indications has been added to this today. Any simpler methods other than IVF? Yes. Intrauterine insemination, popularly known as IUI. What are the criteria? It should be both the tubes should be patent. It should be a moderate male factor, unexplained infertility, mild endometriosis, and many more. So these are all the indications for IUI. What do we rationale for IUI? Increase in the gamete density at the natural site of fertilization. So it involves ovulation induction, sperm preparation, avoid vaginal acidity, avoid cervical mucus hostility. Bolus of concentrated normal sperm is kept as close to the oocytes as possible. That is, in the closest to the portion. You put it inside the uterine cavity, it travels only to the short distance in the tube. What is the ovulation induction protocol? Normally, when they plan to conceive, you aim for only one oocyte. If you do an IUI, you have to aim for about 2 to 3 follicles so that chances will be more. If you are going to do an IVF, then you have to take at least 10 to 12 follicles. That is the difference between an IVF and IUI. What are all the protocols? One is combination of clomiphene citrate from 2nd day to 6th day, human menopausal gonadotropin from 5th day to 7th day and 9th day, or you start with only a human menopausal gonadotropin from 75 international units from day 5, or low dose HMG in case of polycystic ovarian disease, small dose of 37.5 milligram daily, start from 2nd day. Ultimately, your aim is to make sure that you get only about 2 or 3 eggs, not more than that. What is the methodology? Here, semen collection, semen preparation. There are different types of techniques, swim up, density gradient, and there are some newer devices which helps you, about which we'll deal it later. And then the capacitated sperm is inseminated with a simple IUI cannula, and then we give luteal support for the follow-up and wait for the pregnancy. How do you assess or at least predict or presume will become pregnant? Here you will see on a y-axis less than 1 million, 1.5 million, 1 to 5 million, 5 to 10 million, 10 to 15 million. So on the timed intercourse, it is about 0.2% chances. If it is 1 to 5 million, it is about 1% chances. If it is 5 to 10 million, it is 2% chances. And if it is 10 to 20 million, chances are 2.5%. Overall, probably around 3%. If you do an IUI, it increases to about 7% as per the protocol. However, when you do a controlled ovarian hyperstimulation, along with this, then there is an increase in about roughly 10%. So this is the standard protocol with which you have to counsel the patient. What is the difference between the timed IUI, intercourse, IUI, and then controlled ovarian hyperstimulation and IUI, depending upon the semen parameters there. The success rate is about 15% for the woman under the age of 30, 12% when he's aged between 30 and 35, 7 to 8% for the woman ages 35 to 39, less than 2% for the woman over the age of 40. So the age plays a very important character. The next is the semen factor. So this two you decide, and then you do an IUI. How many IUIs you can just do? For example, if the woman is less than 34, timed intercourse, probably you would try for about 3 cycles. The life cycle analysis says more than 3 chances of pregnancy are low. If they cannot afford to go in for an IVF, probably you can extend it by another 3 cycles. Beyond 6 cycles, do not do IUI. The next is what is IVF? IVF, in vitro fertilization, is a method in which eggs are fertilized by sperm outside the mother's uterus. The resultant embryos are then transferred back into the uterus. Only 2 in number, remaining are frozen at minus 197 degrees centigrade with liquid nitrogen. The steps in IVF are, first is pre-IVF investigation. We have to make sure her thyroid is normal, prolactin is normal, she has got a normal ovarian reserve, FSH and LH are normal, no evidence of hyperandrogenism. All this has to be evaluated. Then you come for controlled ovarian hyperstimulation. There are several drugs used there. In an IVF, we normally go for only gonadotropins because we aim for about 10 to 12 oocytes at the end. So we have to go in for gonadotropin. This gonadotropins can be a human menopausal gonadotropin, which is economic, or recombinant FSH-LH combination, which is a little more expensive. So based on the patient's characteristics, based on the basal hormonal evaluation, then we decide what is the drug which is more suitable for this particular patient and then start the stimulation. When you stimulate, we have to keep on monitoring that patient right from day 7 onwards. When you try to take it from day 7 onwards, what actually happens is sometimes you see the eggs are being very prominent. They come up very well. And when they reach the size of around 13 or 14, we give the antagonist to prevent the endogenous LH surge. And then at the appropriate time, where it is something like 18 millimeters mean follicular size, we trigger ovulation. Once when you trigger ovulation with either a HCG or a recombinant LH, HCG, we have to aspirate the oocytes by about 36 hours later. And then we fertilize it, incubate it, select the best embryos, transfer the embryos, give them luteal support, and then try to look for pregnancy test after the 14 days. The methodology of ovulation induction, as I mentioned it, we have clomiphene citrate with gonadotropins, or gonadotropins only, which is urinary, recombinant FSH, or recombinant FSH combination in the form of a 2:1 ratio, which is available as Pergovaris, which most of us have started using today. The gonadotropins with agonist and antagonist. That is, the purpose is you have been loading the patient with the drugs, but supposing if the patient ovulates before you plan for your pickup, what actually happens? So you have to produce a medical hypophysectomy. So that means there should not be any endogenous hormones. So for that, you can use either an agonist or antagonist. When you use an agonist, previously we have been using it from the previous cycle. Sometimes we start using from first to 12 days, and sometimes we use it on a 3, 4, 5 ultra short protocols. But today, most of the drugs are used with antagonist protocol, where from 7th day of the period, we start using the antagonist till we trigger. Advantage, immediate suppression, good cycle control, complete prevention of ovarian hyperstimulation. We have a new long-acting FSH where you can inject on the 2nd day and ask the patient to come on the 7th day. Then after that, you have to use this FSH daily. So that is the long-acting FSH there. Growth hormone is again used to convert a poor responder to a better responder. About 4 international units of growth hormone are used from day 7, day 9, and day 11. But a lot of studies, including from India, has been published, large-scale studies, but it has not been very evident, and then it is not cost-effective when you look at the price of growth hormones there. So the success of ovulation induction in achieving a pregnancy is highly variable. It depends upon the diagnosis, age, the medication used, quality of the patient's eggs, quality of the sperms, quality of the resultant embryo, and then the receptive endometrium. And there are so many other factors are responsible for prediction of a pregnancy there. In an ovulation induction, as I mentioned it, natural cycle, 1 egg. In an IUI, at least 4 eggs. In IVF, we aim for about 10 to 12 eggs there. You will see in the picture there, the follicles will be shown like this, honeycomb appearance, all of them of uniform size. We use a transvaginal ultrasound with the biopsy probe and directly go to the thing. We use a suction apparatus, which is seen here. This has got minus 100 degrees, 100 millimeters pressure, very mild pressure, with which we trap into your tube and collect all the thing and identify it in an inverter scope and then use it for ICSI. So there are different types of incubators available. This is a simple carbon dioxide water jacketed incubator. And this is a tri-gas incubator where it is oxygen and nitric oxide are used. And here it is a dry incubator where it is there is no water jacketing there. So we use all of them. For identification, we use it in the dry incubator. After the ICSI, we put them on tri-gas here. It all depends upon the practice. How do we select the sperm and then take out for injection? PICSI. PICSI is nothing but physiological ICSI, where you take a small petri dish, make a small scratch with hyaluronic acid, and then put the sperms there. The best motile sperms will go close to that hyaluronic acid and then get attached there. That sperms, when you take it out, probably that is the best sperm. Second is the intracytoplasmically morphologically selected sperm. Normally, when you do an ICSI, we do it at about 600 times magnification. When you use it by about 6,600 times, there you use a IMSI. It is time consuming. Probably you will be able to select the best sperm for selection. There is another entry called magnetic max there. So in that magnetic assisted cell separation techniques, where they use all the apoptotic agents are removed, the active sperms are separated there. There are some sperm separation device where I'll show you. So you put culture medium on one side, the semen sample on one side. So all the debris goes to one end, and then the live sperms come to the other end, with which you do it. There is a microfluidic semen preparation available ready-made, with which you'll be able to do it. This is, you see a high quality egg, neat, round, no inclusion body. So here you see a poor quality eggs where there's a lot of inclusion bodies are there. ICSI is where you use on both the sides 2 arms. With one arm, you steady the egg here like this. And then on the other arm, you just take the sperm, cut the tail, and then take only the sperm head, directly injected into the cytoplasm, withdraw a little bit, then inject the whole thing and come out. So this is ICSI, where you assume that fertilization is taking place. So if you look on the third day, you see the uniform cells are here, no inclusion bodies. It's a good quality embryo. Here, cells are uneven. There is a lot of inclusion bodies are here. So then it is a lower quality embryo. There are some other methods of selecting an embryo. There are non-invasive methods. It is by morphological appearing. As I mentioned it, uniform cell size, there is no inclusion bodies, you can just take it. Or time-lapse imaging, where a microscope is fixed with video, and then in that particular video, there's a continuous recording of what is happening in the embryos, and they pick out which embryo decides earlier, and then with that, they just do it. Then we have kinetic. It is a timed events occurring during the development time can be taken. There are some invasive methods where PGT, pre-implantation genetic testing. This is when the cells are somewhere around 16. When you take one cell or 2 cells, they are totipotent cells. Other cells will perform the function and then they become normal. So you will not lose any part of the body when they develop into a human organ. So the totipotent cell biopsy is taken and then studied with the NGS platform. And that is what we call it as a pre-implantation genetic testing. Omics is when you keep the embryos in a petri dish, and after 2 days, when you just take out the petri dish culture medium, from that you assess what is the amount of metabolics the patient that embryo has consumed, and from that you just derive at the status of the embryo. So this is a non-invasive method which is becoming more popular now for selection. After you select it, you load into a catheter, then gently introduce it inside the uterine cavity. 1 centimeter away from the fundus, you slowly, gently inject it and then withdraw the tube. This is embryo transfer is done without any anesthesia. Relax the patient and then do it. Home pickup is done under general anesthesia, but here, thing is. Normally, in an ART law, only 2 embryos are allowed to transfer. The remaining embryos are taken into a process of vitrification and they are put into the tanks under liquid nitrogen for storing, and they can go right up to about minus 197 degrees centigrade. ART laws recommends you to keep it for 5 years. Fertility preservation, we keep it for 10 years, but the time is, there is no definite answer to it. You will be able to preserve it. Because we transfer 2 embryos, so there is a multiple chances, multiple pregnancies are common with IVF, roughly about 37.4%. When we are transferring more than two embryos, it was resulting in triplets. But today, since the law says only two, we only get into a multiple pregnancy, which is a twin. We do not come across triplets. There is a prematurity because of the average with triplets is about 33%. 85% of them will survive. Prematurity goes in the higher order, less percentage decide depending upon the facilities available. There are some fetal risks like mental and physical disabilities, such as blindness, cerebral palsy, 5% in twins, and 10% in triplets, and 50% in quadruplets there. The fetal risks are, again, death 7 times more likely to die in the first year, 40 times more likely to die in the infancy. Maternal risk are toxemia, diabetes, and hemorrhage. Family risk, depression, social isolations, sometimes even can result in diabetes. Multifetal pregnancy reduction, if it is more than 3, you pass a small gentle needle by about 9 to 10 weeks under ultrasound guidance, inject potassium chloride solution into the amniotic fluid, thereby it results in the death of the fetus. So if you reduce the triplets to twins, chances of them going out to term and delivering and having a healthy baby is more. And if it is a triplet, probably they go in for a premature failure, premature abortion, and then prematurity, and then they might lose all the 3. That is the reason this concept of multifetal reduction has come. IVF is definitely expensive. Cost of the injections are very high, and repeated visits to the hospital. Egg retrieval is done under anesthesia. Fertilization is done in the laboratory. Sometimes we use assisted hatching with laser, and cryopreservation of the embryos, which has to be paid until they use it. Every 6 months, they have to keep paying. Lab tests are also expensive because all of them are hormone-based. However, the success is very limited. As I mentioned it, 20% to 25%. But the patient expectations are very high. Hence, lot of issues when the patient gets into a negative report. Appropriate counseling, appropriate positioning of the patient is very, very important before you take the patient for IVF. There are some additional costs in an IVF, which is the hospital cost. Singleton, twins, triplet, the chances goes higher. Intensive care of the baby, if it happens to be in a premature. The work time lost, daily medical visits. Frequently, it is not covered by insurance. And freezing of excess embryos, again, is not covered by insurance, which you have to keep paying every 6 months. There are a lot of other methods which came. ZIFT is a zygote intrafallopian tube transfer. GIFT is a gamete intrafallopian tube transfer. And all the procedures have come. But out of it, today, there are only 2 procedures which have stood the test of time, which is IVF and ICSI. Only these 2. The sperm aspiration is for percutaneous epididymal sperm aspiration, testicular sperm extraction, and the MESA, where microepididymal sperm aspiration. Out of the TISA is again conventional there. Now, this is the question each patient will ask you. What is the take-home baby? If I just go through the procedure, what is the take-home baby? One of the first questions in the most couple of us, what are the chances of success? The best estimate is the birth of a live baby occurs approximately 25% of the women whom embryos are transferred. The nationwide, it is approximately in an IVF registry, it's around 24.9, which is more or less synonym to 1 out of 4. Success, again, varies with various factors, including the number of embryos. And if 1 embryo is transferred, there is approximately 7% chances of a successful implantation. And 2 embryos, success rate goes up to 18. The rate peaks with each embryos, 3 to 4 embryos. But however, our ART law permits only 2 embryos to be transferred at any given time. Presently, the collection of the eggs, fertilization, early embryo are all accomplished with a very high degree of efficacy. So because our improvements in the laboratory techniques there. There are some newer developments which has taken place in ART. The first one is long-acting gonadotropin. As I mentioned it, every day the patient has to come for injection. However, when you take a long-acting gonadotropin the second day, it will act for about 6 days, Korea Life Alpha. So then after that, the patient can come only on the seventh day. It minimizes 6 days of hospital visits. So that is the latest development. But however, after that, you go into the conventional method. Every alternate day, we just keep measuring it. IMC is where I have just said, when you magnify the sperm head to about 6,600 times, you will be able to accurately see the defects in the head, which cannot be seen by a normal mechanism. So, but it is time consuming. It takes about 4 hours for an IMC. PIXI, as I mentioned it, is a physiological ICSI using a hyaluronic acid. Max is again one of the new devices, doesn't cost much. With that, you'll do it. The last one here you see is a microfluidic technique. So here what you do, you put the culture medium here, put the semen here, and you will see that all the debris will be collected, best motile sperm will come here. So this is a disposable device, which is costing somewhere around 8,000 rupees. Another thing is assisted hatching. What is assisted hatching? The outer covering, that is the zona, when it is thick, even though fertilization has taken place, forms in multiple, it does not hatch properly. So we slice the outer zona by using the laser in the corner like this. So it is called assisted hatching. We do it in Sims Hospital. My embryologist has got an excellent result with that. The second advancement is an endometrial receptivity array. We develop a good embryo, we transfer the good embryo, but still our results are only about 25%. How best we can improve on that? When we analyze it, there is one thing called endometrial implantation window. If you can, the window opens, accept the embryo, and then closes. So if you can identify that window and transfer the embryo at that particular time, you get an excellent result. So in order to identify, they take a biopsy of the endometrium in the previous cycle, analyze about 238 genes, and then find out whether it is a receptive endometrium or pre-receptive or a post-receptive. If it is a receptive endometrium, on the same day we transfer on the next cycle. If it is a pre-receptive, 1 day later we transfer. If it is a post-receptive, 1 day earlier we see that. The another advantage is selecting embryo is a spent culture, which is the non-invasive, where it is done only for a fresh embryos, not for a frozen. Fresh embryos, when they grow from day 3 to day 5, we take out the culture medium, the petri dish, which is left behind, and then study the metabolics of that, and then decide which embryo is the best, and then we'll use it for a transfer. So this is again slightly more expensive when compared to the other methods, but however, it is least invasive, so it is more advantageous. If it becomes standardized, probably everybody will go in for a spent culture medium. Pre-implantation genetic diagnosis, there are two things. One is PGS, pre-implantation genetic screening. The other one is PGD, which is a pre-implanted genetic diagnosis. If I have to explain about this too, PGS, pre-implantation genetic screening, is something like going to the library and checking out how many books are there. You get the number of books which is there, fine. That is the PGS. And PGD is you go to the library, take out one book, take out one chapter, and take out one paragraph and find out whether there are any spelling mistakes there. So that is called PGD. So that means you should know what you are looking for. For example, if you are looking for a hemophilia gene, so you have to identify the gene, check the embryo whether that embryo contains that hemophilia gene. So that is called pre-implantation genetic diagnosis. If you have the diagnosis and then you are searching for the embryo whether it is affected or free from the disease, it is called pre-implantation genetic diagnosis. Looking for only an aneuploidy, whether the number of chromosomes are normal or single, haploid or euploid, when you want to see, that is called PGS. By looking at the haploid embryos, then when you transfer, then your chances of pregnancy increases by about 50%. PGD is done only for deceased. When you have a known disease where you have identified the gene, prepare a gene probe and then try to take it. One simple example is the Duchenne muscular dystrophy in the family, where you can check and then see whether it is affected or not affected. A lot of noise has been named after the cloned human embryo. What is the process of cloning? You take the egg cell, keep the chromosome, donor cells are there, the nucleus taken out and put there, and then there is a chemical reaction with which shock and kick started developing. So that means there is no fertilization, no male and female process there. This is called cloning. So this particular person is currently introducing humans cloning from an undisclosed country with Dr. Severino Antroni and Ben Abraham. The, the goal is providing children couples, childless couples with ability to clone themselves as a form of reproduction. But however, it is not ethical today. It has not been accepted. Now you have come to one full round. You will see here Robert Edwards standing with Louis Brown, and then her, this is Leslie Brown. This is Leslie Brown, and this is her daughter Louis Brown. She had a normal child born to her. So that one full cycle is completed. What a proud man. He's no more with us now, but all his experiment has just come a long way in just leading us in the field of assisted reproductive technology. So here I have seen and I have interacted. I was with Professor Robert Edward, and then I had an excellent reviews from him, and then which has just taken me to this kind of a steps there. This is the Professor Andrew Van Statagam, who has done the IVF, the first time ICSI in the world, where he has injected the sperm inside. He is from Belgium, and he is the father of ICSI. And these are all some of the real pioneers who have done the work in assisted reproduction, which has put us into this particular thing. We have come a long way, starting from just looking, admiring the eggs, and then looking at the fallopian tubes, and then looking at the ovary, up to an IUI, from that IVF. So many developments have come, and with that, we are here today wondering what is it a fantastic science or it is just a real amazing dream. Thank you very much for your patient listening.
Thank you so much, sir, for your wonderful presentation. We do have some questions from our audience if you'd like to take that up.
Yeah.
So, sir, the first question is, can you discuss the role of artificial intelligence and machine learning in optimizing treatment protocol for assisted reproduction?
Yes. The first important thing is we go by our standards. When we get a patient for an IVF, we think that her BMI is 30, her FSH is so much, her AMH is so much. So probably I presume that this is the dose of gonadotropin to be useful. Here, lot of standards have been developed, lot of algorithms has been developed. So if you put into the artificial intelligence program here, probably you will be able to get a good ideal starting dose with which that patient will have a good number of abilities. So there won't be a cycle to cycle variation. The second is when you do an ICSI, we manually do the ICSI. It varies from person to person. For example, if I have 3 embryologists, one will have a good result, one will have a better result, one might have a poor result. So here, when you use an artificial insemination, robotic ICSI, your treatment results are uniform and with which you will be able to do it. But you need a large number. We cannot use a robotic ICSI for a person who's been doing around 30 cycles a month. If they are using about 3,000 cycles a month, something like Belgium, where the robotic ICSI will be very useful. There is definitely a place for artificial intelligence and robotic medicine. So here in ART, but as of today, we are not ready.
Thank you so much, sir. The next question from our audience is, what are the emerging strategies for optimizing ovarian stimulation protocols in assisted reproduction?
Yeah. The first is finding the starting dose. As I mentioned it, if you find the correct starting dose, that will be a good thing. We take age, we take BMI, we take AMH, we take AFC, antral follicular count, and look at the previous cycles and then come into a correct conclusion. This is the drug, this is the dose which is required for this patient to get it. That is number one. We optimize the stimulation. Second is, today we have all been using only an antagonist protocol. For the simple reason, it is very comfortable. It prevents OHS completely. And then a third important point is, when you're using an antagonist protocol, you can always use an agonist to trigger. When you use an agonist, the HCG is a culprit for ovarian hyperstimulation. So if you want to avoid HCG, use an agonist trigger. 2 milligrams of lopride when you give, then probably you will be able to trigger well without going in for a OHS. And with that, you will be able to get it. However, on that particular cycle, you have to wait and watch. You should not transfer, and the endometrium is not converted that time. Then probably in this next subsequent cycle, from a frozen embryo transfer, you'll be able to do it. Third important point is the type of the ovulation trigger, the stimulations. As I've said, human menopausal gonadotrophin, which is very economic, contains equal amount of FSH and LH. Second is recombinant FSH, which is a purely isolated FSH. Third is pergovaris, where it is 2:1. FSH and LH both are recombinant, which is commercially available. You have to choose the optimal patients to receive the stimulation. Thereby, you will be able to achieve a good results.
Thank you, sir. So there is one last question from our audience. How has the utilization of egg freezing evolved, and what factor influenced the success of fertility presumption in women?
Yeah. There are 2 types of freezing. One is called slow freezing. Slow freezing is where you take the egg into a -10, -20, -30 in the form of a programmed freezing. You need a programmed freezer that costs nearly about 10 lakhs. So with that, you take down to -197. The problem is there is some amount of crystallization of the embryo which takes place at that particular time, or the oocyte. However, when you do vitrification, it is something like jumping into a pool from a deep, high wave. Directly, you use a vitrification agent and then plunge itself directly into the minus liquid nitrogen, which you do not require a programmed freezer, which is very economic. There again, the vitrification has brought in lot of efforts, lot of newer things, and improved the success rate of an embryo. Again, when you come into the fertility preservation part of it, when it is being done for gonadotoxic patients following a cancer surgery, before the surgery, before chemotherapy, you take the thing, vitrify the embryo, If the patient and the husband are available, create an embryo and then preserve them. If the patient is a single with no partner, take out the eggs and preserve. If the patient is young, prepubertal, no partner, then take the oocyte, ovarian cortex alone by using a laparoscopy, peel something like an orange peel, cut it into small pieces, and then preserve it, what we call it the ovarian cortex cryopreservation. When she becomes old, when she starts menstruating, when the chemotherapy is completed, you can take the small cells and implant it into the ovary by different tunneling methods, with which she will start resuming a normal hormonal influence. So this is called the fertility preservation, where it is used the vitrification and slow freezing techniques. You can freeze egg, you can freeze the embryo, you can freeze the ovarian cortex.
Thank you so much, sir, for answering all our questions. Before concluding today's session, any last remark from you, sir?
Um, Assisted reproduction is really a feat. It's a scientific feat, and all of them should know what is it all about. All of them, both the treating general physicians, treating OGCians, ART technicians, should know what is happening all around the assisted reproduction. Judiciously use selected people in the centers where the facility is available, and then guide them to achieve their goal.
Thank you so much, sir, for joining us today.